Welcome back to ASCP Preparation Camp, where we turn complex medical topics into clear, unforgettable lessons. In this episode, we're diving into something you have to understand if you're studying liver disease or preparing for the ASCP exam: acute hepatitis. Acute hepatitis refers to a sudden onset of liver inflammation. The causes? Some are direct, like toxins from an acetaminophen overdose, or a lack of blood flow due to ischemia. Others are indirect, meaning your immune system is doing the damage, like in most cases of viral hepatitis, some medications, and even alcohol-related liver injury. Now here's where it gets interesting. The pattern of injury can differ based on the cause. If it's direct damage, liver enzymes in the blood tend to rise rapidly, and then fall quickly, following their natural half-lives. But when it's immune-mediated, like in viral or autoimmune hepatitis, the enzyme levels rise more gradually, often plateau, and take longer to return to normal. Is jaundice always present? Not necessarily. It's a key clinical clue, but many viral cases can fly under the radar without it. So how do we catch it early? Liver enzyme tests. If AST or ALT levels are significantly elevated, that's a major red flag for acute hepatitis. Alkaline phosphatase, or ALP, on the other hand, is usually just mildly elevated in these cases. What about bilirubin? It can go up too, often both direct and indirect, but on its own, it won't help distinguish hepatitis from, say, bile duct obstruction. The good news? In most cases of acute hepatitis, the liver's ability to make proteins remains intact, which is why many people fully recover. Let's talk about how we differentiate causes. It's not just seeing elevated AST and ALT. It's the pattern and the context that matter. Stethoscope, for example. In viral hepatitis, AST and ALT shoot up, often over 1000 IU/L. In alcoholic hepatitis, AST tends to be about twice as high as ALT, but the total levels may not be extreme. Toxic or ischemic injury. Those levels can be sky-high. Drug-induced injury might look more cholestatic, so ALP is higher. Autoimmune hepatitis. Think low albumin, high globulins, and positive autoantibodies. Wilson's disease in the acute phase. Clues might include hemolytic anemia, kidney issues, and a low ALP to bilirubin ratio. Acute bile duct obstruction from gallstones. Might mimic hepatitis at first, but ALP rises more slowly and bilirubin is mainly direct. See what I mean? It's the whole picture, lab values, symptoms, and patient history, that tells the real story. Now let's zoom in on two classic forms of acute viral hepatitis. Starting with hepatitis A. About 70% of adults with acute Hep A will develop jaundice. It tends to hit harder, and last longer, in people over 60 or in those who already have liver disease. In someone with chronic hepatitis C or cirrhosis, a new HAV infection can even trigger acute liver failure. It's a big deal. Diagnosis. Look for IgM anti-HAV antibodies. They show up early and stick around for months. We don't usually test for the virus itself in the blood. Next up, hepatitis B. This one's tricky because the outcome really depends on the patient's age and immune status. In young kids, it's often silent. In adults, about 1/3 show jaundice. But here's the critical point: the risk of chronic infection skyrockets if the person was infected as a newborn. Only 1 to 3% of healthy adults develop chronic HBV, compared to up to 90% of infants infected at birth. And again, diagnosis relies on serologic patterns. Watching how antigen and antibody levels shift over time helps determine the stage of disease and its chronic potential. Now let's take a closer look at acute hepatitis C, and why it doesn't follow the same playbook as hepatitis A or B. First of all, antibodies aren't always present early on. In the US, acute HCV makes up a smaller slice of all acute hepatitis cases. And only about 10% to 30% of patients develop jaundice. So when does it show up in labs? Well, liver enzymes typically start to rise about 6 weeks after exposure. Jaundice might not appear until 2 to 3 months later. But here's the key: HCV RNA and core antigen can be detected much earlier, often within 2 to 4 weeks of exposure. That's when the viral load shoots up, even though the antibodies are still lagging behind. Unlike hepatitis A and B, anti-HCV antibodies may only be present in 50% of patients at the time of clinical presentation. And don't count on IgM anti-HCV to clarify things. It isn't reliable for distinguishing acute from chronic infection, because it can be found in both. So how do we diagnose acute hepatitis C? You should suspect acute HCV when HCV RNA or core antigen is positive, but anti-HCV antibodies are negative. Or if there's a high viral load and anti-HCV is just beginning to rise. The viral load usually declines as antibodies develop, sometimes going undetectable temporarily. And get this. In 30 to 50% of people who clear the infection naturally, anti-HCV antibodies may never appear at all, or they could disappear over time. That's why recognizing acute HCV early is so important. Because if it doesn't clear on its own, early treatment within the first 6 months is highly effective, and can prevent it from becoming chronic. Now, not all hepatitis is due to the classic A, E viruses. Other viruses like EBV, Epstein-Barr virus, and CMV, cytomegalovirus, can cause acute hepatitis too. They often mimic viral hepatitis, showing up with elevated liver enzymes and fatigue. But they usually come with other systemic symptoms. Take EBV, for instance, the virus behind mononucleosis. Think sore throat, swollen lymph nodes, and fatigue, along with elevated liver enzymes. CMV can be more subtle, but still inflames the liver. And herpes simplex virus, HSV, while rare, can cause severe hepatitis, especially in adults with compromised immune systems and in newborns with disseminated infection. How do we diagnose these? Typically, using serologic tests for virus-specific antibodies. Or nucleic acid testing, PCR, to find viral DNA or RNA in the blood. But remember, these aren't liver-specific tests. One last thing worth noting. Flares of chronic hepatitis B can sometimes look exactly like acute hepatitis. You'll see a sudden rise in liver enzymes, maybe jaundice, and it might be mistaken for a brand new infection. But here's the trick. To tell the difference, doctors track changes in HBV antigens and antibodies over time. And work to rule out other causes. Let's now shift our focus to something a little more alarming: toxic hepatitis. And topping the list of culprits? Acetaminophen overdose. This one's a major cause of liver damage, especially in North America and Europe. But what makes it so dangerous? Well, toxic hepatitis happens when the liver is directly damaged by a chemical or its metabolite. It's usually dose-related and predictable, and acetaminophen is the #1 offender. Here's how it works. Under normal conditions, the liver breaks down acetaminophen through several pathways. But when there's an overdose, these pathways get overwhelmed. And more importantly, glutathione, the liver's protective antioxidant, gets used up. Once glutathione runs out, a toxic byproduct called NAPK builds up. And this is where the real damage begins. And here's the scary part: even lower doses can be dangerous if the person drinks alcohol heavily, is malnourished or fasting, or even just takes slightly too much over several days. Diagnosis. History is everything. We measure blood acetaminophen levels, and if it's a late presentation, we might look for acetaminophen protein adducts. Lab pattern. Usually PT rises first, then AST and ALT spike, often reaching 100 times normal around 24 to 48 hours, before starting to come down. But don't be fooled, a falling enzyme level doesn't always mean recovery. If PT remains high days later, or the patient develops kidney failure, acidosis, or low blood pH, these are bad signs. Now let's talk alcoholic hepatitis, another toxic form, but with a twist. This is an acute inflammatory condition seen in chronic heavy drinkers. Patients might show up with fever, high white cell count, elevated acute phase reactants. But here's what sets it apart. The enzyme levels aren't that high. AST is usually about 2 times ALT, but the overall rise is modest, rarely more than 8 times normal. Why that ratio? Well, chronic alcohol use affects the liver's vitamin B6 stores, particularly pyridoxal phosphate, which impairs ALT more than AST. Also, mitochondrial AST gets released more with alcohol damage. In about 20% of cases, we see a cholestatic form, with a significant rise in alkaline phosphatase, high bilirubin, and worse prognosis. Again, clinical suspicion is key: heavy alcohol use, AST, ALT2, and a white count bump. Now let's address a tricky one. Drug-induced hepatitis, a true diagnostic puzzle. Unlike acetaminophen toxicity, most drug reactions are idiosyncratic, unpredictable, not dose-related, and often immune-mediated. Lab patterns can mimic viral hepatitis. Sometimes we see a cholestatic picture, high ALT and very high ALP. So how do doctors figure it out? It's all about pattern recognition. Is there a reasonable time frame between starting the drug and liver injury? Are other causes ruled out? Any signs of general immune reaction? Like rash, fever, joint pain. Does the liver injury reappear on re-exposure? There are scoring systems to help, and published case reports can provide clues. Don't forget, supplements and herbal remedies can also cause drug-induced liver damage. And timing varies, it can hit within days or after months. Up to 60% of cases are severe, with jaundice. And in some, the damage doesn't reverse, even after stopping the drug. Now for 2 important mimics of acute hepatitis. Autoimmune hepatitis and Wilson disease. Autoimmune hepatitis is usually chronic but can present acutely in up to 40% of patients. Clues include low albumin, high globulins, slower enzyme decline. Diagnosis: exclude other causes, then look for autoantibodies. Wilson disease, a genetic copper storage disorder, often has neurological symptoms, but can also present with sudden liver failure. Look for low ceruloplasmin, low ALP, hemolytic anemia, renal signs. Other mimics include hemolysis, increased bilirubin and LDH, no ALT bump. Muscle injury, elevated AST or ALT but normal bilirubin. Acute bile duct obstruction, initial ALT spike, but ALP and bilirubin follow. So how do we put all this together? When someone walks in with acute hepatitis, the first step is recognizing it: elevated AST or ALT, often 10 to 100 times normal. Next, find the cause. Start with a detailed history: medications, alcohol use, travel, recent exposures. Initial lab tests typically include IgM anti-HAV, HBsAg, IgM anti-HBC, anti-HCV. Sometimes HCV RNA or core antigen if HCV is suspected. What patterns should we notice? AST/ALT 100x normal equals likely toxic or ischemic. AST-ALT ratio about 2, moderate elevations equals think alcoholic hepatitis. Sudden RUQ pain and ALP rise equals maybe bile duct obstruction. Imaging, like an ultrasound, is crucial for identifying gallstones or blockages. If other signs like low albumin, high globulins, anemia, or kidney failure are present, we investigate for autoimmune hepatitis or Wilson disease. And when viral hepatitis is on the table, HBV, HCV, and even HIV testing is important, including viral load testing. Keep in mind, high ALT means inflammation, but the degree of elevation doesn't always tell us how bad the damage is. So, what exactly is chronic hepatitis? The defining feature is a persistent elevation in liver enzymes, particularly aminotransferases, for more than 6 months. That signals the need for thorough investigation. Liver biopsy can be incredibly valuable here. It helps determine not just the cause, but also the severity of inflammation and the stage of fibrosis. This insight is vital to choosing the right treatment. The most common causes: chronic hepatitis B and C, non-alcoholic steatohepatitis or NASH, autoimmune hepatitis, inherited disorders, and chronic drug-induced injury. Under the microscope, we typically see ongoing hepatocyte damage, attempts at regeneration, and scar tissue formation. We now classify chronic hepatitis by its cause, inflammation grade, and fibrosis stage. Let's focus on chronic hepatitis B first. It's a major player globally. 350 million people are infected. The virus itself isn't usually toxic to liver cells. Instead, it's our immune system's ongoing attack on infected cells that causes damage. This happens when the immune system can't completely clear the virus. Many patients with HBV have a weak interferon response, which is our body's natural antiviral defense. That's why interferon alpha has been used as a treatment option. Sometimes, the immune attack isn't limited to the liver. It can also involve blood vessels or kidneys, due to circulating immune complexes with hepatitis B surface antigen. In patients with HIV co-infection, viral replication is often higher, but inflammation may be less, which unfortunately leads to a worse long-term prognosis. HBV progresses in different phases: active replication, quiet periods, and inactive carrier states. The risk of cirrhosis and liver cancer is directly related to how high the HBV DNA levels are. Treatment aims to normalize liver enzymes and suppress HBV DNA to very low or undetectable levels. Polymerase inhibitors are effective, though the duration depends on the patient's HbAg status. While a complete functional cure, loss of HbSAg, is rare, it's more likely with interferon or tenofovir therapy. Now, let's turn to chronic hepatitis C. Roughly 170 million people are infected worldwide. Unlike HBV, the risk of developing chronic disease isn't tightly linked to age at exposure, and vertical transmission is uncommon. Once HCV persists beyond 6 months, spontaneous clearance is rare. The viral load might remain stable or gradually increase. Over the years, 20 to 30% of patients will progress to cirrhosis, especially those infected later in life, men, alcohol users, or immunocompromised individuals. Surprisingly, some patients, about 1 in 3, have normal ALT levels. But that doesn't mean the liver is fine. Even with normal enzymes, significant fibrosis may be progressing silently. Treatment has been revolutionized. The goal is a sustained virologic response, or SVR, undetectable HCV RNA 24 weeks after completing therapy. That's considered a virologic cure. It significantly lowers the long-term risks, even for patients with cirrhosis. Now, what happens in HBV-HCV co-infection? It's a complex situation. About 2 to 10% of people with HCV also have HBV, and up to 20% of chronic HBV patients may have co-infection with HCV. These patients often have lower viral loads for each virus but experience faster liver damage. Co-infection is more likely to lead to severe hepatitis and cirrhosis. In some cases, HBV replicates in the liver without detectable surface antigen, making diagnosis tricky. Beyond viruses, we must talk about non-alcoholic fatty liver disease, or NAFLD. It spans from simple fat accumulation to NASH, non-alcoholic steatohepatitis, which includes inflammation. NASH can eventually lead to cirrhosis and liver cancer. It's often seen in people with metabolic syndrome, obesity, insulin resistance, hypertension, and abnormal cholesterol levels. Diagnosis is often incidental, maybe an elevated ALT or ultrasound finding. Confirming NASH typically requires a liver biopsy. But we've made progress with blood tests and non-invasive fibrosis scores like the NAFLD fibrosis score and FIB-4. Even modest weight loss, just 1%, can significantly reduce liver fat. Some anti-diabetic medications show promise, but data is still evolving. Then there's autoimmune hepatitis, or AIH. Here, the body mistakenly attacks its own liver cells. It can progress quickly and has a high mortality if untreated. Though relatively rare, AIH is a notable cause of liver transplants. It tends to affect women more than men and can occur at any age. Diagnosis involves checking for specific autoantibodies, ANA, anti-actin, anti-LKM1, among others. Elevated IgG levels and compatible liver biopsy help confirm it. Immunosuppressive therapy, often prednisone with azathioprine, is effective in most cases. Inherited liver diseases also matter, like hemochromatosis, Wilson's disease, and alpha-1 antitrypsin deficiency. Hemochromatosis causes iron overload and is linked to mutations in the HFE gene. Early detection through transferrin saturation and ferritin tests allows for treatment by regular blood removal. Wilson's disease is a disorder of copper metabolism. It can cause psychiatric and neurological issues alongside liver disease. Diagnosis involves ceruloplasmin levels, 24-hour urine copper, and genetic testing. Alpha-1 antitrypsin deficiency is a genetic disorder that can cause both lung and liver disease. Diagnosis is through serum levels and gene testing. Some medications can also cause chronic drug-induced liver injury. It's harder to pinpoint and often mimics chronic hepatitis. Offending agents include nitrofurantoin, methyldopa, statins, and even herbal supplements. Now let's talk about cirrhosis, the final common pathway for many liver diseases. It's marked by irreversible scarring and architectural distortion. Some people may have compensated cirrhosis, no symptoms, only lab abnormalities like low platelets, elevated INR, or low albumin. But once decompensation begins, ascites, jaundice, bleeding, the outlook worsens. The Child-Pugh and MELD scores help assess severity and determine transplant eligibility. MELD uses bilirubin, INR, and creatinine and is considered superior for short-term prognosis. Next is acute on-chronic liver failure, or ACLF, an abrupt worsening of cirrhosis with organ failure. It carries a high short-term mortality. We also explored cholestatic liver diseases, like primary biliary cholangitis, PBC, and primary sclerosing cholangitis, PSC. PBC affects small bile ducts, mostly in middle-aged women, and is strongly associated with antimitochondrial antibodies. PSC involves both intra- and extrahepatic ducts and is often linked to inflammatory bowel disease. PSC has a high risk of cholangiocarcinoma and colon cancer. Finally, let's not forget hepatocellular carcinoma, HCC, the most common primary liver cancer. It often arises in the setting of cirrhosis, particularly due to HBV, HCV, alcohol, or NASH. Surveillance with ultrasound every 6 to 12 months is key. Alpha-fetoprotein, AFP, is a commonly used tumor marker, though it has limitations. Other markers like AFP, L3 and DCP may help in some cases. And with that, we wrap up this deep dive into chronic liver disease. We've covered the wide spectrum, from viral hepatitis to autoimmune, metabolic, and genetic disorders. The liver has remarkable resilience, but when overwhelmed, the consequences can be devastating. So, let's ask ourselves, what choices are we making today to protect this vital organ for tomorrow? Thanks for watching. Don't forget to like, subscribe, and share this video if you found it helpful.